and Ramadan Kareem. It's my pleasure to welcome you to the Brookings Doha Center's fourth webinar covering various dimensions of the coronavirus pandemic. We've been thrilled by the positive response and reception to our webinar series and by the engaged audience it has been attracting. In order to stay true to our mission of serving the people of the Middle East and North Africa, we provide simultaneous translation in Arabic. To select English, please use the English interpretation channel at the bottom of your Zoom screen and click on Mute Original Audio. للمستمعين باللغة العربية سنستخدم قناة اللغة الفرنسية للترجمة الفورية باللغة العربية. باختيار العربية يرجى النقر على French و Mute Original Audio عبر برنامج Zoom. Okay, so today we are discussing the public health dimension of the coronavirus pandemic in the Middle East and North Africa region, or the MENA region. The pandemic has taken a devastating human toll on the region, with over 360,000 confirmed cases and close to 12,000 deaths to date. The pandemic has pushed the region's public health systems to their limits. The region's healthcare professionals are working with determination and dedication to manage the pandemic's fallout and minimize its impact. However, MENA countries differ greatly in their capacities to test, trace, quarantine, and treat affected individuals. MENA governments are also varying in their access to medical supplies and expertise, as well as their willingness to be transparent about the extent of the crisis in their countries. Healthcare staff in some countries have to overcome weak institutional capacities, shortages of supplies, and sometimes uncooperative populations. So what has the pandemic's impact been on the region from a public health perspective? And how are MENA countries dealing with the pandemic? What policies should governments prioritize in the months ahead? We're privileged today to have with us an esteemed panel of experts. Dr. Hanan Abdulrahim is Associate Professor and Dean of the College of Health Sciences at Qatar University. Dr. Mohammed Verji is Associate Professor and Assistant Dean for Student Affairs at Weill Cornell Medicine in Qatar. And Dr. Samih El-Saharty is a Lead Health Specialist with the World Bank. So after an initial discussion with our panelists, we will open for questions and answers. Attendees may submit questions anonymously via the Q&A option in Zoom. So, all right, so let's begin. Dr. Hanan, let me begin with you. According to international experience, what does a successful COVID-19 response look like? And to what extent do we see elements of this response in the Middle East and North Africa region?
Good afternoon, Nader and colleagues. So I think when we talk about successful responses to COVID, a lot of examples come to mind from Asia, like Taiwan and like South Korea being usually held up as the gold standard, but also other countries like Iceland, for example, and New Zealand. And when you look at everything that has been published and when you look at their data, you realize that there are actually just a few points in common that kind of crystallize what a successful response looks like. The first was a very organized governance mechanism. That is incredibly important, to have an emergency governance system in place that is ready to go and ready to function in a very decisive manner. That was true of most of the countries that had a successful response. Early and aggressive action. And that's interesting because right now there are a number of groups looking at public health measures and what their effect have been. So some at the London School of Hygiene, at Oxford and elsewhere. And what seems to be important is not just aggressive action, but early aggressive action. And that helps when you have a good governance mechanism in place. I think another thing that was incredibly important and that we always talk about is the ability to test widely. So the testing capacity and being able to scale up that capacity very quickly has been very important, so that you're not only testing people who are presenting with the symptoms, but you're also able to test much more widely, and therefore to get an idea of the transmission of the virus more generally. Also, I think countries that have had good success are ones that leveraged technology and ICT solutions for various purposes during the epidemic response. So if you think of South Korea, for example, very heavy use of technology in tracking and tracing. And that was very important because tracking and tracing can actually be very burdensome if it's all being done manually, especially as the infection gets broader and wider. So it was very important that some countries are able to leverage technology for their quick and successful responses. I think what's also very important is a very strong sense of a very strong ability to communicate with people, because as you can see, a lot of the epidemic response depends on good public health action. So everything that's being done before getting to having to use the hospitals and the ICU and so on, and that requires a lot of cooperation and compliance from people. So being able to communicate very effectively, to explain what measures are coming, to explain why those measures have to happen, has, I think, served some countries much better than others. So I would say that those are the probably the most important factors in what a successful response would look like.
Thank you very much. Dr. Samih, so we heard a little bit about what a successful response would look like. How did the various measures taken by the Middle East countries and the GCC contain the pandemic and manage its spread from a public health perspective? And do you think these responses, how do you think they compare to other countries in the regions across the world, along the lines that Dr. Hanan mentioned?
Okay, Dr. Nader, thank you very much. Do you hear me clearly?
Yes, we do. Okay,
good. All right. So first of all, thank you very much for this kind of invitation with my two distinguished co-panelists. I really appreciate the opportunity. Well, to respond to your question, specifically in the GCC countries, they have taken a number of measures to try to contain and mitigate the COVID-19. First, the first measure was early closure of borders and international travel, which helped in controlling imported cases. That was probably the most important first step to be able to control borders and reduce transmission. That was also coupled with cancellation of major conferences, major public events, banning of large social gatherings, in addition to lockdown measures. Also, they had a very good system of test, trace, and isolate. And there are good examples of drive-through testing in Bahrain and United Arab Emirates. There is also the application of digital technology, like in the case of Kuwait, where they had an application called Shlonak with a tracking bracelet that was given to all Kuwaiti who were coming from abroad. And that helped a great deal in isolation as well as reducing institutional quarantine. They also did very well in terms of protecting the health workers. Also, they had very rigorous communication campaigns, focusing on personal hygiene and physical distancing. And lastly, in some instances, there were
It looks like we may have.
There were some.
No, you're back. Okay, sorry, Dr. Samir, you had slipped out for a minute on the internet.
Well, yeah, I mean, unfortunately, the bandwidth, the connection is not that stable. So anyway, and however, the results were mixed. While the GCC countries were able to control to a great extent the imported cases, we're still seeing a rise in the number of cases because of local transmission. Okay, so when we look at the trajectory of the cumulative cases and week-to-week progression, we see that the cases continue to rise. And to answer the second part of your question, how does this response compare to other regions? Maybe we can look at 3 metrics. First is the preparedness. And when we talk about public health response capacity, there are 2 aspects here. First is the preparedness capacity, and then the response category. According to the international health regulations, WHO has made an assessment of the capacity of different countries to respond to COVID-19. In the case of the GCC, the United Arab Emirates have an assessment of 5, which is the highest, and all other GCC has a score of 4, which is similar to most of high-income countries and upper middle-income countries, whether globally or in the region. The second aspect is response category, which reflects the risk of exposure to COVID-19. And again, because of the transmission in all the GCC countries has made it into localized transmission, so the risk is high. This is category 4. Now, this is in terms of the first metric, which is public health response capacity. The second one is evolution of number of cases. As I mentioned earlier, when we look at the trajectory, the week-to-week increase in number of cases continue to rise. And again, that means that more needs to be done. Testing, all have high number of testing, actually among the highest, particularly in Bahrain and UAE, have something like 104 and 124 tests done per 100% population. And also that can explain, Dr. Nader, the rise in number of cases. As we all know, with more testing, we detect more cases. So this is expected. And the last part is the case fatality rate. The number of people who die from those who are tested positive. And across all GCC, it's below 1. And actually in Qatar, it is the lowest, which is a very good sign. A good sign of the ability of the healthcare system really to tackle and deal and manage critical care cases as well as reduce fatalities. I would just end by saying that, just to echo what Dr. Hanan has mentioned, that the importance of focusing that there is need to be done. And there are 3 things that are critical. First is scaling up testing. This is critical. Second, maintaining social distancing and not to relax measures for the time being. And particularly in the case of the GCC, the working and living conditions of the low-wage foreign workers is a challenge, and that needs to be improved because right now, this is where the clusters of transmission is occurring. Over.
Thank you, Dr. Samir. Much appreciated. Dr. Mohammed, Dr. Samir briefly mentioned the situation in Qatar and also touched on maybe a little bit on the wider Middle East region. How about Qatar? How do you see Qatar's handling of the COVID-19 pandemic? And how does it compare to other countries in the Middle East and the world?
Well, when the first news of COVID started to emerge, at that stage, Qatar didn't have a single case. And so what happened was this lead-in, with starting in Asia and then moving across to Europe, allowed Qatar and the Middle East and the Gulf region states to prepare in good time. So they were very proactive. In that case, providing for testing was one consideration, but also looking at the definition of the population concern was another, because information began to emerge to say that it affected certain age groups. Perhaps those over 80 were more at risk, those over 70 were lesser but still at risk, and of course comorbidities were an issue here too. So if you had 1 or 2 comorbidities, it didn't seem to matter later on whether you were actually 80 or 70 or younger. We know that it affects everybody. The one area that is perhaps not always appreciated in Qatar is that we have a very young population. And the young population seem to be able to counter the virus more successfully than those who are actually much older and, as I've mentioned before, have had a comorbid condition. As Dr. Samir actually mentioned, testing is critical, but I also think that Qatar has done a very good job, like other countries, but particularly I can speak with authority on Qatar. They have actually looked at all the parameters and they've provided the testing that's required. There's drive-in testing by swabs. Now you don't have to get out of your car and do anything. The number of beds set aside for people who are convalescing has reached 11,000 plus. We have 30 hotels at the moment who've been taken over to look after people in quarantine. Those who actually have been told to self-isolate have mostly and large listened. The businesses are closed, but food shops are open. So the police are actually very firm, although gentle, they are firm. And there's been some discipline about how this situation is handled in the public domain. So one of the things that is important is the so-called R number. And the R number is really the infection rate. We have heard that the R number of ordinary flu is estimated around about 1, which means one person can infect one other person if they're in close proximity. The major difference between COVID and ordinary flu is that the R number, the infection rate, is one person can infect 3, and then those 3 can infect another 3, and so on. So as opposed to one person in flu affecting 10 people, the others actually, the other way, the COVID can get to 81 very quickly, and that's a vast difference. The transparency and the information on sometimes a twice daily basis is very helpful, and they're simple for everyone to understand. Unfortunately, there was an outbreak in Iran, and there were a number of people who happened to be infected while they were there. When they came back, they were all put into quarantine. All the people who actually were in contact with them were put into quarantine as well. Anybody who was suspected of having any symptoms was put into self-isolation, and so it continues. So I think really the one last factor I want to mention is the case fatality ratio, which again, Dr. Samir mentioned. The case fatality ratio in the moment in Qatar is 14, which is almost incredible. It's very low in the UAE as well. It's pretty low in Saudi, and it's very low compared to, say, something like Italy or Spain. And this actually is very reassuring. So we have had, the government has looked after it, so it's very well in health, and we've had the capacity to handle the people who needed ventilators, for instance, without necessarily being stressed out. Very, very fortunate for any country to be able to do that. We've heard about the troubles in the US and how they were under pressure, particularly in New York, but we've managed to cover all those cases. They've got 4 allocated hospitals separate from the general hospitals, so there's no mixing of COVID patients coming in and then people who actually have other problems, cardiac or surgical problems, etc. So I think that the important thing was that everybody is on board. There have been, of course, outbreaks in various communities, and some of the low paid workers who live perhaps closer together they've had small pockets of that. But the important thing, I think, and here is the humanity aspect, everybody who has been infected, who needed care, has received the care, as you would hope in any country. But we know that certain countries were so stressed that they were not able to meet that objective. Everybody possible who has been in potential danger has been seen, treated, and looked after. So the 3 things I want to emphasize is the testing, again, which Dr. Samir mentioned, the age group, which in fact is very, very important, and the number of intensive care beds which are available to fill and treat all those in need. I think that's really how I can encapsulate Qatar's own action, and repeated by many other states there. But this has been so far a very, very important issue to make sure that the public are sensitized but are not scared or frightened, or shall I say, dare I say, are irresponsible in any kind of behavior.
Thank you, Dr. Mohammed. So Dr. Hanan, Dr. Mohammed was mentioning many factors in Qatar's case, and Dr. Sameh and the wider GCC, including issues of the youthful population, institutional capacity, in terms of how they were handling it, the COVID pandemic in these countries. So to your mind, what are some of the public health factors that are specific to the wider Middle East region? Such as public health spending, demographics, vulnerable populations throughout the region, and institutional capacity. And how uniform are these factors across Middle East and North Africa countries and sub-regions such as the Gulf? I mean, most sub-regions aren't as fortunate as countries of the Gulf Cooperation Council in terms of their resources.
Thank you, Sam. No, that's exactly right. I mean, the Arab world, when you talk about the Arab world or about MENA, it's a pretty diverse region. So you have countries that are quite fortunate in terms of resources and institutional capacity and so forth. And Qatar is a very good example of that. And we've seen that reflected in the testing, in the availability and preparedness of hospitals and tertiary care. But then you also have other countries in the region that, you know, don't have this level of resource, and they don't have this institutional capacity. So my first point is that the Arab region is a very broad spectrum. A lot of factors are at play here in terms of how we are able to, or how the broader region is able to deal with COVID. One of them, of course, is public health. I mean, if anything came out of this crisis, I think it is to finally give public health the recognition that it deserves. For so long in the region, and in other parts of the world, in all fairness, there has been you know, much more attention, certainly many more resources given to clinical care, but not necessarily to public health action. And I think, if anything, this epidemic has shown us that public health is very important. And so the public health capacity in the region was not necessarily very strong. I mean, for most countries, we don't even know what proportion of the health budget goes to public health. It's very hard to get those numbers for most of the countries. We don't know how much money is spent, and very little actually is spent on public health. It's mostly usually on secondary and tertiary care and on clinical care as opposed to public health activities. So that's one factor. And it's important because, I mean, all of us just sort of talked about all the important public health actions such as testing and tracing and so on. And if you don't have that capacity, and if you don't have the public health labs, then that is a great disadvantage in terms of your response. The demographics, I mean, you're right, and you know, my colleagues have also touched on that. The region as a whole is a pretty young region. Even countries that tend to have older populations, they're still, relative to other parts of the world, they are still pretty young and therefore relatively healthy. So that, I think, has been in many ways a very important factor in the region. I mean, despite all the problems that we see in the region, you know, relatively speaking, we haven't had, you know, catastrophic fatality ratios. And I think a lot of that has to do with the demographics. I mean, that's certainly been a blessing. The country is also home to a lot of refugees in the world, and that's a problem. I mean, we talk about, in the Gulf region, we talk about the labor population living in dense areas. If you look, you know, more broadly across the region, then you also have the issue of the refugees, and you know, in several countries, whether they're living inside or outside of refugee camps. And even there, still, fortunately, I don't think we have you know, heard about catastrophic events there. But For refugees, I think the problem has also been not just the disease itself, but also the economic hardship that has been compounded by the lockdown measures and by the more global economic depression that is happening. So for refugees, I think that's a very, very real problem, not just the health conditions, but also the worsening economic conditions and the impact that it has on an already very, very vulnerable population with very few resources to spare or to fall back on. And finally, I mean, one factor that I talk about that maybe in our region, and again, I mean, this might be the blessing in disguise, we're not very used to working intersectorally. So we're not very used to intersectoral collaboration, and that is absolutely key in the epidemic response. And we've seen it in countries that have done very well, I mean, including in Qatar, but we've seen it in other countries as well, that the only way that the response can be successful is if you have a lot of non-health actors also being involved. So this is usually, and we've seen this with other non-communicable diseases, with other health issues that are not necessarily epidemics or infectious diseases. We've seen the difficulty of working, outside of the Ministry of Health or outside of the health sector more generally, and to cross over to other sectors. And that collaboration has absolutely been important. And hopefully one of the things that will come out of this situation is sort of more attention being given and more experience now with intersectoral collaboration. The only other thing I'd add to this is, we've seen a lot of countries across the region that don't necessarily have a lot of resources, and yet they were able to manage the epidemic reasonably. And I take Jordan as an example, right? So Jordan has been one of the Arab countries that, if you look at their epidemic curve, it's looking like it's flattening and it's almost flat. And I think with Jordan and with many other, some other Arab countries, what was lacking in resources, I think, was made up for in very, very strict public health measures. So if you look, for example, at Google mobility reports, and you see the reduction in mobility of populations. If you look at the Jordan data, some of it is down, 85% or 80% in different areas of daily life. So I think the very strict lockdown measures and the strict public health measures were taken there out of necessity, because a lot of countries can't afford the critical care and to have large numbers requiring advanced hospital care. So that's kind of the summary of the Arab region so far. And again, emphasizing that it is a very diverse region in terms of resources and vulnerabilities.
Thank you very much, Dr. Khan. Dr. Samir, how about a bit more perspective on the GCC countries, which you discussed previously, and the consequences of the pandemic on public health systems and health services in the GCC countries? And I'd like you to take a special, I'm looking over, we're getting some questions now from the audience, and a lot of the questions actually, I'm going to try grouping them as much as I can into categories. A lot of the questions are about the GCC, but they're also about a group of people that Dr. Hannah mentioned. We also have vulnerable populations here possibly, which is the migrant workers. So a lot of people are asking about how the migrant workers have been handled in the GCC countries. And maybe you can speak to that as well.
Sure. All right. I mean, first, on the aspect of the impact of COVID-19 on health services, there are two aspects here. First is the COVID-19 itself, and that is putting pressure on the need for respirators, ventilators, masks, other personal protective equipment, as well as the need for hospital bed capacity increase. So this is like one part of the pressure on the healthcare facilities, in addition to pressure on the emergency facilities, as well as healthcare providers. That's on COVID-19. Then you have the effect that is not, usually mentioned a lot, which is the impact of routine non-emergency services. This pressure from increase of COVID-19 cases is actually taking a lot of space from this routine care. And there is some data that shows that, for example, most elective surgeries have been postponed. Some 50% reduction of regular and routine care. There are about 8 million patient contacts that are canceled per week, and about 40,000 healthcare professionals that cannot deliver care due to lockdown. So COVID-19, in a nutshell, is putting pressure on healthcare system to provide care for COVID-19 patients on the one hand, but also it is negatively affecting, to a certain extent, the care that is needed for non-emergency patients or non-emergency care. So that's also, regarding the impact of COVID-19 in the GCC on health services. And the other question was on, if you remind me?
Some migrant workers in the Gulf, yes.
Well, migrant workers is a major issue, because as I mentioned in my earlier remarks, the GCC were able really to contain and control all imported cases through very rigorous system of detect, isolate, trace and isolate. Then transmission started locally, particularly among migrant workers. And if you look at the trajectory, the increase was relatively slow in the first few weeks. Then it started to rise almost exponentially from 1 week to another. And these transmissions were mainly among migrant workers. And for obvious reasons. One is that their living conditions and working conditions, as we all know, those who live among us in the GCC know that they live in quarters that are cramped. Many individuals live in the same apartment or occupy the same room. And this is a fertile soil for transmission of COVID-19. As Dr. Mohammed mentioned, the R0 or R0, which is basically the rate of transmission, is 3. That means each person who gets infected can infect 3, and these 3 can infect another 3, and so on and so forth. And that's why we observe a large or a rapid increase among the migrant workers. That's one. Also, in some instances, some countries have allowed some services to continue. Like, for example, and this is just an example, food delivery and grocery delivery, which is, these services are mainly done by migrant workers. While maybe at the workplace, there are enough measures, and I've seen this firsthand, there is enough measures in terms of distancing, wearing masks, gloves, and so on and so forth, and disinfection. However, when these workers go back to their living quarters, this is when the potential of increased transmission occurs. So both the living conditions and, even in this case, the working conditions also helped, or unfortunately accelerated, the transmission. Now, having said that, one important factor, probably I can cover this later in more detail, while the infection rate is high, given that they are relatively healthy and young, the number of critical cases and fatality will be extremely low among this group. Over.
Okay, thank you so much, Dr. Sameh. Dr. Mohammed, Your reflection, some of the factors, and actually we're getting some interesting questions, which maybe you can help us answer from the audience. The first is some people are asking about certain issues like the possibility of reinfection and what this would mean. They're also asking about questions about mental health. So essentially some of these outcomes that may prolong the virus or may cause secondary effects. And the mental health question was actually also about regarding children. A couple of people mentioned, that one of the big questions is when do you reopen schools, and what that would look like in the coming year, taking the issues of reinfection and mental health into consideration. So, what are your thoughts on some of these issues?
I think one of the most important things to have been publicly announced is the social distancing. Social distancing actually doesn't quite cover it. It really should say social and physical distancing. And if in fact, even if you have family, you don't know their circle of movements, you don't know where they've been, who's been in touch, who's been close to them. Families unwittingly could infect families, although of course they are family and they're trustworthy in that sense. But this infection, looking at the widespread and the increase in figures that Dr. Samir went through earlier, if you look at Italy or Spain or France or Germany, there have been even higher numbers of spread and infection. So social distancing really is something to adhere to. Now, one of the things that we have been worried about is second wave and reinfection. I want to say that the infection, as far as we know, COVID, once it infects you, you are effectively cured, inverted commas, from the infection once you have a test again for COVID and you are negative. And that requires 2 tests 24 hours apart. Now, once it's eradicated, we're not entirely certain whether people are still potentially infected. The big factor here is that people who are infected may be totally asymptomatic, not have any signs of illness at all, and yet be in contact with people, and then subsequently people that they meet or mix with get infected. So having adhered to self-isolation, quarantine, sometimes mandatory, and in fact, making sure that all the hospitalized people are looked after. If we actually then decide that life is going to resume on a fairly normal basis, that is unfortunately a premature thought. Lots of countries in Europe, including Britain last night, Prime Minister Johnson gave an announcement, and they have certain levels of danger, 5 being the worst, and 1 being the least, well, basically no restrictions at all. We know that people have it in mind. That concept is also prevailing within the Gulf. But one lesson we've actually have to learn is with Germany, who dealt very well with people who developed the disease and had a relatively lower case fatality rate compared to the other European countries, has now gently released the restrictions, and now we're seeing a second wave, outbreaks in bars and what have you. So that is a risk. In South Korea, they've actually isolated another spot in social areas where there's been an increase. In Wuhan, in China, they've actually been another little mini break. So yes, the chances of people being infected afresh from those who are already infected is definitely a possibility. However, I would like to think, and I hope, that those people who are completely cured, who no longer have the COVID virus in their body, sorry, slip of the tongue there, COVID virus in their body, they are basically cured and not infected anymore. Whether in fact they can be reinfected is something we are not certain of. It seems a possibility, but it doesn't seem likely at this time. What people are actually doing right now, what countries are doing, are they're trying to take serum plasma from people who've actually recovered and have been cleared with no evidence of active disease, active virus in their body, and using their serum to use it perhaps as an antidote and to help other people get better. So-called passive, if you like, passive immunization. But we haven't seen the trials go far enough to have a complete conclusion about that. Now, when it goes down to the changing of health, I would say that all of us on this earth, nobody has ever been through this. We've seen the history, we've seen the pandemics. The pandemics go back centuries, if not eons, in fact, to before Christ. Those times, we know about them, they're written about. But right now, we have not been able to have a manual to say this is what you do. People are experiencing the trauma of the disease. First of all, at the extreme end, deaths of beloved ones, deaths of parents whom you expect to live in old age and then suddenly are gone within a week. That kind of trauma. The people who are young, the medical frontline workers, there were a number of doctors who came out of retirement in Italy, and I think of those, about 70 perished from COVID-19. The effect on everybody has been immense. I'm not sure that anybody could stand back and say, I know how to cope. Now it's been a various number of weeks for all of us, including our children. The children loved it when, in fact, they didn't have to go to school. They were bouncing around and enjoying themselves. And it also allowed for reconnection with families, no travel, no activities. They were focused in the home and what have you. But then the novelty wore off. And now children are actually tired of being at home and they want to go back to school. When the schools do reopen again, and we don't know when that's going to be, I'm sure they'll be very excited to go back to school. And obviously a lot of people have suffered from exams, and exam results have been missing. We're going to have a generation never before had where students are going to be considered for university entry without actually having formal GCs or IB or whatever. So I think this is a very real and important factor. The mental health, everyone's doing as much as they can to try and reassure people that we actually are going to be okay at the end. But the long-term effects, and those particularly who are vulnerable, who may already have mental problems, they are going to need to be looked after and watched quite carefully. It's up to them, of course, to seek help. But I can see quite a rise in consultations with psychiatrists or psychologists or general doctors or counselors for a while to come. I want to say that we're all in it together, and we should all help each other as much as we could, as much as we can. And so, really the question of the help, the change of pattern of life, the change of values, the change of importance, the application of humanitarian help is going to be extremely, extremely apparent. I hope so anyway, for the future. So we can all eventually come out of this and say, we remember 2020, but it's past us now.
Thank you, Dr. Mohammed. I think we have time for kind of one more round of questions at the end. And there's a group of questions here that relate to essentially countries that are experiencing crises and conflict, to what extent this becomes a double burden. Countries like Libya that are facing, armed conflict, countries or locations like Gaza, where there's essentially a blockade and people have difficulty coping in any case, and countries like Lebanon where you are experiencing financial crisis. That's a group of questions. I'll let you decide if you want to speak to any of them as we go around one last round of questions. But I would like the last round to actually be looking forward a little bit. So maybe I can start with Dr. Hanan. So when should countries, and building on what Dr. Mohammed said just right now, when should countries look to begin to start easing restrictions, and what will this require? And if you can reflect also on managing the second wave successfully, maybe just a little bit look to the future about what can be done. And for any of the speakers, if you want to weigh in on the issue of conflict countries, please do.
Okay, thanks, Nader. So let me start with your question first, and then I might add something about the countries in conflict. So, of course, everyone now is considering the question of when they can start easing, restrictive measures now, and when life can go back to semi-normal. And we've seen some cautionary tales from around the world of countries that seem to have been doing fine, to have the epidemic under control, and now we're seeing some spikes again, and Singapore is one of them. And so it's a very precarious situation. I think it is inevitable that we cannot maintain this level of restrictive measures and lockdowns and so on for various reasons, whether they're economic reasons or even the mental health reasons and people's ability to cope with this. There's a lot of fatigue right now around the world with COVID-19 and with how it has changed life. And so, those are all things to consider. So I don't think that a country should consider restrictions without thinking about a number of things. One, what does the daily infection rate look like, the rate of new cases look like? So if you don't have a sustained decline for a couple of weeks, then I think it's too early to be thinking about lockdown. So you want to see a sustained decline in new cases before you can begin to think about lockdown removal. You also want to think about, well, once you lift the closures, are you ready for any spike that might happen? Because there will be an increase in cases. So do you have the PPEs needed for healthcare workers or for other workers that you will have? Do you have the ICU beds to deal with it? Do you also have the public health capacity to track cases once someone tests positive and to track contacts and so on? So you have to have very good public health capabilities in place for contact tracing, so that as soon as a new case is identified, or try to predict where a cluster might be, that you can try to contain it as quickly as possible. You want to have the clinical preparedness in place, so the hospitals and the ICU beds, and your numbers really have to be going down in a sustained way for a while before you can consider that. Now, one of my colleagues talked about the second wave, and there is inevitably going to be a second wave. And I mean, not to be entirely dire, but I think it's going to be probably even harder than what we're seeing now, because already people are economically worse off, countries are economically worse off as a fallout of what has happened with this wave of COVID-19. So when a second wave finds us, it's going to find us in sort of an economically exhausted place. It may also coincide with the seasonal flu. So I think that's something that the health care facilities are going to have to be very vigilant about and to be very prepared about. So I think what is going to be most important going forward, because the easing of restrictions is inevitable, but I think the name of the game is going to be agility. So how agile are countries in terms of being able to quickly detect and to contain very quickly any resurgence and deal with it. So people have to be, and countries have to be very used to monitoring, but then reacting very quickly. There can't be long times of indecision. Should an airport be closed? Should we close down schools? I think we've learned a lot of lessons from this wave, and we should be able to implement those lessons very quickly, because again, I'll say what I said at the very beginning. It's not just aggressive action that's important, it's timely action that is important. That makes a lot of difference. So countries need to be sure that they have the capacity to monitor and then to detect and then to track and to trace cases and to contain the situation very quickly. And I think the public also has to be psychologically adapted to the fact that there's still a lot of uncertainty, and we need to be ready and agile and flexible to move from a situation where we're sending our schools one day, but then it might be that in the next we're told to keep them home, or that we are back to going to work on some sort of normal basis, and then we switch again. And that's why I say the second wave, that I think that the countries that will really do well are the ones that learn the lessons of this first round, but that are also going to be ready and very, very agile in making decisions and in implementing measures.
Thank you. Thank you very much. Dr. Samia, so looking forward and going forward, what do you think are some of the public health considerations, maybe with regards to such things as opening the economy? And we have a couple of questions actually about the importance of regional cooperation as well. I don't know if you can address those as well in your closing comments.
Okay. Well, this will take a long time to answer all these questions, but let me try to be brief and also focus on what's important. In terms of the public health considerations, probably there are so many considerations. I'll focus probably on 3 or 4 of them. First is the epidemic force, which is the rate of contagiousness. As was mentioned earlier, for COVID-19, it is 1 to 3. That means each person infected infects another 3 persons. We need to have this rate below 1 to be able to consider reopening the economy. As Dr. Hanan mentioned, that would mean we need to observe 14 days of declining new cases. That's one, epidemic force. The second consideration is population health. And here we have age and health status. So if we have more older people and people with comorbidity like cardiovascular diseases, diabetes, obesity, and other risk factors, then the probability of opening the economy will be less because of the large number of these people. And if it is more younger and healthier people, then in this case, we can open the economy. In some instances, we can what we call cocoon these people. So all those who have comorbidity and above the age of, let's say, 60 or whatever, can be staying at home, not going to work, just to protect them. This is like one measure. The third consideration is public health capacity and service capacity. And I think Dr. Hanan already covered that part, the importance of having the health system ready to take care of a potential increase in the caseload. Now, the last one, or the most critical one is technological and scientific innovations. And this can really help a great deal in considering reopening the economy. Probably COVID-19 is the most digitally tracked pandemic in history. I mean, instantly we are observing mobility, tracking mobility, and tracing people, and all of this information is being fed into mathematical models that inform public health professionals and policymakers. So we can make use of this technology to enable us to target which sectors of the economy can be opened and which geography. So these tracking tools can help us in this regard. The second part of the technology is the scientific part, which everyone is talking about, which is testing, treatment, and vaccines. And on testing, there are 2 tests that can help us consider reopening. One is the PCR assay, which identifies the virus, and this will help us, which is now going on, which will help us identify who is infected. Once this will help us identify those and isolate them and trace their contacts. The other test is the antibody test, and there are 2 types of tests. One is for immunoglobulin G and immunoglobulin M. M is for the short antibodies life that remain in the blood for about 2 or 3 weeks, while immunoglobulin G stay for a longer time. That means that these people who have this type of antibodies have developed some immunity. It's not full immunity, but these we can deal with in terms of their ability to be mobile and probably go to work. I'm saying this with a lot of caveat because 2 things. Not all the antibody tests are fully reliable in terms of specificity and sensitivity. There is a lot of false negative and false positive. And also we don't know, because this is a novel virus, we don't know its full behavior. So we don't know whether it can reinfect people like influenza does. We all get influenza episodes multiple times in a year or subsequent years. So we don't know whether this immunity will last or not. However, taking all these public health considerations into account, then comes the question of reopening the economy. Because again, it's not going to be a switch on and off, of course, but there are sectors of the economy that are more prone to reopening. And we look at 2 factors here, the health risk and the economic downturn, or the economic benefit, if you will. So if in an industry or a sector, the potential of transmission or risk of transmission is low and the economic benefit is high, then this can be reopened. An example is manufacturing, where in factory lines, you can actually have distancing between workers, sanitize the place, disinfect the place entirely before the work starts and between shifts, and allow them to work. So, and the economic benefit and return will be high. So it has to be calibrated, Dr. Nader. It's not a matter of either or, but you have to take all of these into consideration. And of course, it has to go slowly, because I think Dr. Hanan and maybe Dr. Muhammad also mentioned, the research can be dire. We have Singapore, we have Korea, we have Wuhan. Sorry, we have a number of countries who have locked down, and then when they started to reopen, the cases research. Sorry, I'm fasting, so that's why my mouth is dry. Over to you.
Thank you, Dr. Samir. Dr. Muhammad, you have the final word. And looking forward. So, I mean, we're mentioning Dr. Samir and Dr. Hanan both mentioning that there's potentially a second wave. This is probably a long-term thing. So, are people learning to cope with the new realities of self-isolation and quarantine? What can be done to help them? What should we be thinking about as we look forward?
I think one of the things that we will have to do is to learn new skills of how to try and function as normally and as practically as possible, while taking into account the possible dangers not only to adults with comorbidities, but dangers to anybody in the family and to our children as well. So the new skills are going to roll out, and people hopefully will share their ideas. But the mental aspect is something which is unpredictable. I would hope that with a shorter period of lockdown and a gradual opening up, people will be encouraged and actually will look forward with a little bit more optimism rather than fatalism, and say, it was bad, but we got through it. We got this far. Let's go the whole journey. Let's work together and move forward with it. One of the things I think that will be key in all of this will be the development of a satisfactory vaccine. The vaccine, in fact, that will be produced may not be the panacea of treatment, because as Dr. Samir mentioned, we get reinfected with flu every so often, and we have the annual flu vac. But I think that'll be a major step. I think it's also important to know what active treatments are now available and what may become available in the future. Some of them, like Resdemivir, which is a drug which has been shown to reduce the length of the illness are really impractical because they are so expensive. It's $4,500 per course of treatment, and no one is going to have that kind of money necessarily to spend. So it's not going to be, that's not going to be the answer. But it's very important for people to have faith and know the truth about what vaccine is able to be effective. If you talk about Jonas Salk, think about his polio vaccine. He knew what he wanted. He knew what he had to get. He got it, and look at the effect. Polio is virtually eliminated throughout the world, apart from a couple of countries. But we will probably never eliminate, but we can protect ourselves. We need to look at not only our mind, but our bodies. We need to keep fit. We need to have a different type of social connection with connectivity, which is meaningful. We need to actually be careful of our habits. We need to reappraise what we want. We need to reassess our values. We need to actually look at our health and our well-being. And I think also in there, there's a degree of spirituality, which has probably been enhanced. So there's a multi-role factor. But all in all, we will survive. The people in the pandemics before did survive, and we will survive. And we need to have that realistic but positive thought without being over-optimistic.
Oh, that was a really insightful and positive note to end on. Dr. Hanad Abdul Rahim, Dr. Mohammed Farji, Dr. Sameh El-Saharty, thank you all so much for joining us today and for this insightful and very valuable discussion. Thanks also to our audience and to the communications and events team and to the translators who've been with us on this call. And I look forward to seeing you again for another webinar. Thank you all very much.
Thank you.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.